One of the things we see actually at Piedmont a lot is just acute heart failure. And, the management of acute heart failure, whether it be in the cath lab or the surgical arena, is really kind of different. And we kind of have this algorithm we use, which is when you have heart failure, if you're going to use a machine, you should put the machine in where you think the problem is. And so we're going to go through this a little bit and kind of see kind of what everyone thinks. So this is a 20-year-old African-American male who presented to the ED with shortness of breath, chest pain, cool and clammy, and of course he was treated for pneumonia. Who thinks a chest X-ray is normal in a 20-year-old? So. This is really typical for young kids to present. They'll present, literally doing as well as they possibly can up until they fall off the bridge. And typically they'll either do this or they'll be an AFib at 140 and someone will try and break it. And when they break it, they usually arrest. He got treated for that and went home and then came back. Of note, he really does have a pretty good family history of heart failure. His mother had heart failure when she was young and has an EF around 15-20%. His cousin actually had two LVADs up in Charlotte and died from complications. So he had a bedside echo which showed that his ventricle was, as you can imagine, severely depressed. And he had moderate to severe MR, although he wasn't in frank pulmonary edema. He was started on norepinephrine, dobutamine, and epinephrine, and still had a low SVO2. So he's at one of our outside hospitals. So we elected to transfer him. So when he got to the door, he had an elevated lactic acidosis. He was in renal failure, and he was taken to the lab and placed percutaneously on VA ECMO. He was not intubated, but started to really develop kind of some, a bad cough and some frothy sputum. So who thinks, what's the next options of what to do on someone who's fully supported on VA ECMO, not intubated, and has frothy sputum? Okay, so two things said was Impella and unload the LV, and also intubate him. ABC. So he actually had an LV decompression with an Impella. And over the next few days was extubated, and we were looking at him to see kind of how he was doing, and he was okay. Everyone kind of wanted to get him transplanted. I was still nervous because he still was in shock, and we really hadn't reversed his shock yet. And one of the paramount things that at Piedmont we do is we don't really say, well, if you have LV failure, you're on for 7 days, RV failure, 10 days to 14 days. We wait until the shock reverses, and then we decide whether or not to do something. And so he still didn't have his shock reversed yet. So we elected just to kind of watch him. So then he started developing, I'll show you the x-ray. Didn't want to. He developed those infiltrates on the left-hand side. And, so here he is, intubated. He got bronched because we were worried maybe he had some mucus plugging and stuff, and that wasn't it. His airways were actually fine. They had a little bronchorrhea in them, and they're a little bit red, but nothing bad. So we had previously had an Impella in, so we'd spent $18,000 and or $22,000. And so the question is, what should we do for this? And typically, when we have patients who are in florid pulmonary edema and Kool-Aid's coming out of their ET tube, we've typically, depending on the availability of a transseptal guy, we'll put a transseptal catheter in and drain biatrial. But, that kind of bothered me because, everyone still, again, wanted to get him, going. And the other side is that once you decide to go the transcatheter route to drain the left atrium, you cannot walk these patients. there's too much mobility of that catheter, and you'll be popping in and out across the septum. And so then we were going to lock him into being in bed. He's already probably 10 days into this, and so we decided not to do that. So I called Vivek up and said, what do you think about clipping this guy? And he said, sure, let me take a look. So he did. He clipped him and took his MR from probably 3 to 4 down to 2. But more importantly, his LA pressure went from 28 down to 14. And so with that, he was able to get extubated, and that was his X-ray. So now we're kind of about 2 weeks into this and decide what's really the next move for this kid. He's got a big heart. We really have no true understanding of his chronicity and how acute is his heart failure. So, we thought about, doing a biopsy, but what was that going to really tell us? We know he's got bad heart failure. It's too late in the game to give him any kind of immunosuppression, whether give him thymo or high-dose steroids to try and acutely reverse this. So we decided just to continue to watch him. And eventually, after 3 weeks, took him to the operating room and put an LVAD in him, did his tricuspid, his mitral was fixed, and as we were kind of ventilating before we came off the bypass, pleural spaces are open, and I said, are you guys ventilating yet? Oh no, we're full ventilation. I said, what's your tidal volumes? 100 cc's. I said, well, that's not going to work. So his lungs were so stiff. We had airway pressures of 60 to 70, and so I elected to put an RVAD in with an oxygenator. And the way we do it, we put a graph on the PA, and then for him, he's from his ECMO cannulas, he still had a groin cannula in there, which is just in the right atrium, which you can walk with that. So here he is with his RVAD in place. And they have him up on the tilt table just before they're going to start to walk him. So coming out of here is the PA catheter, and this is a graft to the PA, and really is a real safe way of setting this up. He really kind of did very well from that standpoint. We were able actually to wean his RVAD over 2 weeks. And at that time, he was walking around the unit, participating. He was extubated and participating in things. So we were able to try and gain a little bit from the anorexia that he had. So this is his post-operative X-ray. I just saw him in clinic. He's out of rehab. He was sitting in my clinic, and he just immediately stood up. So he's already gotten his quad strength back. He's still tired. He actually walked into clinic. He kind of read my post-op VAD kind of things, which is first time you come back, you can wear slippers and come in a wheelchair. Second time, you have to have a cane. Third time, you need to walk. And he walked in the first time. And when we took out his RVAD, we just took his wires out and put a stapler across the graph, and that was really it. It was pretty straightforward. But the echo was actually very encouraging. His RV was fine. And as you can just see from this chest X-ray, that heart size is already half the size. So we're gonna, we've have him on ACEs now, and he still has a good pressure with his VAD. His pressure is in the 80s to 90s, and he's already on 40 lisinopril. He's on 12.5 of carvedilol. We're going to start him on an ARB, and he's on spironolactone. So he's maximally medically managed for any type of recovery. And when you talk to the folks about recovery, you do that, and you keep on pushing them, and you tell the patient, you're going to feel crappy for the next week, but we have to keep on moving your ACE and your ARBs up. And if we don't do that, we don't get enough unloading of the ventricle. And so he's doing fine. When we took out his RVAD, they thought he was 45 to 50. I kind of kept that under the hat because someone would have said, well, just take everything out, and he needs to recover. So he'll probably recover, and probably give him at least 6 months, because I think that's just the best thing to do for him. So I think the kind of the take-home messages when you're thinking about ECMO and how to take care of patients is really to look at the lesion set of what's happening to the patient, and then take your your therapies and match it. You could we talked about putting in a Protect catheter in him, or putting in a right-sided Impella. And again, those catheters, if you want to mobilize your patients, which is probably as important as what we're doing with all these machines, you can't walk patients with any kind of Impella, and you can't walk them. That Protect catheter is tough because it can migrate, but he's turned out really well. And we took him from what we call an Intermax 1 to now, he's probably a class 2 to 3 heart failure, but he'll be 2 to 1 probably within 6 weeks, I would think.